lecture who's going to tell us a bit about contemporary prenatal diagnosis from a clinician's perspective. Take it away.
Good morning. Thank you very much. I'm here. I was invited to talk about at least what we deal with on the prenatal side. I'm a maternal fetal medicine specialist as well as a clinical geneticist. Did my education at Emory. And so when I started doing genetics and prenatal diagnosis 20 plus years ago, we had the karyotype. And that basically, you know, as most people are aware, that you had to do an amniocentesis for that. There was a moratorium, or at least a brief moratorium, on doing CVS or chorionic villus sampling because of the World Health Organization studies, as well as the CDC studies. And so we really just had a very limited amount of opportunity and a window into the fetal environment. So just to continue from our last speaker, talking a little bit about non-invasive prenatal screening or testing. This is obviously from cell-free fetal DNA. It was commercially introduced into our armamentarium in 2011. It's highly sensitive and rather specific. And there are two types, basically, or two major techniques in which it's done. One is used with massive parallel shotgun sequencing, in which we utilize the proportion of mom's DNA as well as the fetal DNA. By the time 10 weeks rolls around, excuse me, you have about 10% of the DNA that is floating around the mom's plasma is from the fetus. And where that is coming from is actually apoptosis from the chorionic villus or the placenta. And then the second techniques, for the most part, are targeted fetal DNA sequencing. The criteria currently is for high-risk population in which we utilize this. That means 35 and above. Ultrasound findings that are considered to be diagnosed or at least suspect for some type of aneuploidy of 13, 18, and 21. Increased risk via other type of screening, our traditional screening, whether that's first trimester screening with ultrasound and biomarkers, as well as triple screen, quad screen, or what have you in the second trimester. And of course, family history. If you looked at the studies, the initial studies with the high-risk population, the prevalence was 1 in 8 of some type of those three types of aneuploidy. And for Down syndrome alone, currently in the United States, about 1 in 600 live births are children with Downs. So the testing that was done on those studies, the positive predictive value for a patient having a child with Downs or 13 or 21 trisomies would be somewhere in the neighborhood of 90% or so. But if you look at the general population, you're looking at a much lower prevalence and therefore much lower positive predictive value. So what is really the best way to do this? It's really sort of, it's actually not the right question. It's what are you looking for? And so the MPSS that are done by Sequenome and what was Vernata is now continued on with Verify and a couple companies that are dealing with or actually using Verify's technology. Answers one part of that question, but and we were just explaining at the break. They have whenever they collect that data, they're collecting about a terabyte and a half to 2 terabytes of information for each sample. So you talk about information storage in the cloud, if you will. There's a lot of information. And then there's the targeted fetal DNA sequencing, in which they actually try to isolate as much DNA, fetal DNA, from the mom's blood, and then they go ahead and hybridize, amplify, and sequence, or they do a multiplex isolation with SNP analysis. The SNP analysis has a nice application to it because then we can look at more microdeletions and dupes and the like from there. Though the massively parallel sequencing also were able to do that as well. Again, the massive parallel sequencing, if you say, okay, you have all this DNA, you have moms and you have babies, it's all actually done on z-scores or ratios, so that if there's something out of context, then it's either the mothers or the fetuses. So again, we have high sensitivity, over 99% for Down syndrome, looking through the fetal fetal DNA as well as the T18s. However, it's much more variable depending upon the techniques that are used for T13s, and there's much less data in sex chromosomal abnormalities. And again, all these have very low false positive rates. So the false negatives, obviously, is if you do it before the gestational age of 10 weeks. Fetal fraction is becoming less and less of an issue because of the modification of the techniques in which they're doing. But maternal weight and volume of distribution is potentially an issue. Or there may be more apoptosis in mom's body who are obese, and therefore there's more maternal DNA floating around. Genetic variants are always potentially an issue, and then of course the failure to extract any adequate material and individual variation of cfDNA and mom's DNA. And then of course the GC-rich regions are one of the major problems with trisomy 13. False positives, contamination is always a big one. Vanishing twin is probably the largest component of this, where say at 8 weeks or 6 weeks, a twin is there, a dichorionic twin, and passes on, and so you still have some of that fetal DNA running around because even though the embryo may pass, the placenta is still producing and still breaking down. Though the fetal DNA turnover the half-life is approximately 24 hours. Placental mosaicism, obviously more so with the aneuploidies, the 13 and 18 more than 21, and then there's low-level mosaicism, especially in all the sex chromosomal abnormalities in the fetus and in the moms. We were mentioning earlier about different degrees of mosaicism. Moms, as they get older, are at an increased risk, if you will, of a loss of an X chromosome. Not that it hurts them, it just happens. Be a nice research project to find out etiologically why. And then maternal cancers. We're picking up a lot of maternal cancers. And it seems like in the population, in the one company that I'm associated with, or at least I have a number of friends with and have consulted with in the past, their numbers are approximately 1 in 10,000 samples. So they've been able to pick up maternal cancers that way. If you look at failure rates, currently this is the published failure rates. They've gone down from the overall 3%, but note that these are all different techniques and the like. Again, your false positive rate is somewhere at 99.8% or so. But there's no free lunch. And the thought process is that when this technique came out, we're like, are we actually going backwards in prenatal diagnosis? We're dealing with, 20 years ago, we wanted to know about Down syndrome. Well, obviously, the world is a lot different than that. And there are much more syndromes that we're actually discovering every day. So there's a lack of information, if you will, just by utilizing cell-free fetal DNA. But the reality is that it's going to get much better for us. And currently, the associations and the colleges and the congresses all have common themes of currently how to utilize this, but we all know that this is not a diagnostic tool. And I'm not saying that it will never be a diagnostic tool, but we have a lot to learn before we call it a diagnostic tool. And we certainly need to do amnios or CVSs to at least confirm what is being seen in the cell-free fetal DNA. And it doesn't replace other screening tests. First trimester screening with ultrasound and biomarkers. Reality is those biomarkers are very important, as well as the first trimester's ultrasound, where we can pick up 80 to 90% of the major anomalies, and then serum screening in the second trimester, whether it's unexplained alpha-fetoprotein or low unconjugated estriol. They all have their importance during a pregnancy. We can actually tell and potentially predict if the moms are at a higher risk for fetuses that are IUGR, intrauterine growth restricted, or potentially having preeclampsia or other untoward pregnancy events. So basically the future now is how do you, if you have multiples, certainly high order multiples, triplets and above, are much harder to deal with, especially if you're dealing with proportions. Twins, there is some separation data that's out there. Approximately 10,000 twin pairs have been looked at. The sensitivity seems to be reasonable. It's well over 95% and closer to the 98, 99%. But again, if you have concordant or discordant pairs, that's something that is needed to be worked out. Eventually, we'll have aneuploidy for all the chromosomes, just like a karyotype. We'll be able to do that. They have the data. It's just a matter of trying to figure out how well that's going to work out. The GC islands are certainly difficult to deal with. And then currently we have three companies, I'm sorry, that are looking at microdeletions, or actually are reporting out microdeletions and microduplications of the top 10 to 15 that are in a population. And so they are working towards, basically, if you will, a low-density microarray, anything that's greater than 10 megabases. And that's what they're reporting out. Eventually get down to 5 megabases. Probably it will take a while before we get down to a megabase or less. And then single gene defects have certainly been reported with this technique. And so, again, it's just a matter of commercialism and the industrial complex to help us out here. There have been at least 20 or 25 single gene defects that have been detected through cell-free fetal DNA techniques. And then whole genome or whole exome sequencing is probably the ultimate goal. So to switch gears a little bit, I started doing microarrays in the prenatal arena around 2005. We started talking about it in 2004. The difference here is that where we're basically looking at a molecular karyotype, as you know, and the difference is that it's on a much more informational scale. The results and counseling are still from, and even today, are still from our postnatal databases. And the unknowns that we are picking up, and basically this is more of a, not necessarily general population, but it is more of a shotgun, if you will, of trying to figure out what potentially is going on with a fetus instead of a targeted situation where you would have a child in front of you and a dysmorphologist would look at a child and say, okay, you have this, this, and this, and this. We did our regular tests that we thought that might be, and we'll go ahead and do a microarray and see what's going on. The comparative array hybridization was the original technique that had started in this arena. It's pretty much fallen out of favor, and now most people do SNP and oligo arrays, in which there's about a million SNPs and a million oligos that are done, probes. So this has changed prenatal diagnosis. It's increased detection of chromosomal variation, the ability to detect the absence of heterozygosity, consanguinity, uniparental disomy, though heterodisomy is harder to detect because of the lineage. Inherited disorders, if you have a deletion on one side, you may have a mutation on the other side where genes are potentially there, and now you have an affected or a semi-dominant situation. And triploidy. Both these techniques miss the true balance translocations. So our experience in the over 5,000 pregnancies, we looked at these patients over from 2004 to 2011, and we knew all the aneuploidies by karyotype, so we excluded them. We did not include fetal demises. Our detection rate of an additional 5% of abnormals, though 6% if they had an abnormal ultrasound, and 8% if they had an abnormal demise, respectively. And so we had a copy number variation of about 0.4%, which is much less than what we started with in the beginning of about 4 to 5%. We also noted that 71% were below the resolution of the karyotype. Remember that fetal chromosomes are highly condensed, and there are about 300 bands. And so this is 10 megabases, and thus, which is astounding to me that 29% of these should have been detected by regular karyotype, the deletions and duplications. Then we looked at those specific anomalies on ultrasound. Of those clinically significant alterations in the genome were identified by a single ultrasound marker. That was about 5.6%. If you had 2 or more organ systems involved, that number went up to about close to 10%. If there was an individual growth abnormality, if the baby was overgrown or undergrown, then it's about 2.5%. And any type of soft markers, if you will, was also about 2.5%. Some surprising high detection rates: holoprosencephaly, 10%; posterior fossa defects, close to 15%; skeletal anomalies, 10%; VSDs, 10%. Only one of those was a 22q11. And hypoplastic left was about 16%, and cleft lip and palate, which everybody thinks is really pretty benign, about 10%. So these are clinically significant microdeletions and microduplications. So what about the general population? Well, Wapner published in 2012, approximately 5 or 6 months after we had published our data, and showed that 1 out of 60 patients with had an abnormal CMA for AMA alone with no ultrasound findings or an abnormal serum screen, meaning that 1 out of 60 patients were dealing with having a clinically significant microdeletion or duplication in fetuses. So, the unknowns we have a lot of issues with, and patients have a lot of issues with that. But it's not necessarily an issue for us as far as the doctors, but it takes a lot of time talking to the patients and navigating and trying to figure out what we can do. We have a lot of work to do, and education is a big thing. There's a lot of paradoxes, and in the next hopefully 5 years, a nice paradigm shift. But it's non-invasive versus diagnostic, getting some risk versus no risk, less or detailed information, missing clinically significant disorders, or variants of unknown significance. Explaining false positives and false negative tests to patients is always a challenge. And then the pleiotropic phenotypes for all these genetic disorders. Contiguous gene syndromes, we were only just discovering with 22q11. Now we have all these other deletions and duplications that we're trying to figure out. And I had a patient with a 22q13 deletion, and she was perfectly normal as far as intellect. And she gave birth to 2 children that had Phelan syndrome. So, go figure. So, education for the public and the professionals is a large challenge. So, thank you very much. Questions?
Sure, thank you.
Thank you. Open for questions, Krishna?
Is yours mainly a clinical setup? It's not clear to me. It's a little unusual to find this kind of work in a hospital setting, really, because I've spent most of my life both in hospitals as well as academia.
Yeah, I'm actually a clinician now. I mean, I've been in academics for a number of years,
Yes.
but I keep my academic associations and continue to do. I love doing the clinical research, and so I continue doing that.
Right, right. And the next question is, your basic population is really what, random sampling? Is that what it is? Randomly you choose patients? Or I noticed at one stage you have n equals 2,000 numbers or something.
Right.
Is that in 1 year or multiple years? Or no, there's no.
Both those particular publications with the 5,000 and the close to 3,000 patients were between 2004 and 2011. So they were not random patients. These were patients that were going to Signature at the time, and we went through the whole database of what was there. And so all the positive findings. And the first publication was all their prenatals, and then the second publication was all all ultrasound findings.
So these are basically women who came to the hospital for some reason, some
Well,
prenatals?
we basically do all types of screening.
All right.
So if there's any type of risk issue, whether that's an ultrasound finding or what have you, they'll have an amnio or a CVS. If the karyotype was normal and the patients wanted further testing with microarrays and the like, then they go on and have that done. And the American Congress of OBGYN has changed their stance on not to do it versus to do it, and that was in 2009.
Right. You chose only maternal age 35 plus. That's what you were talking about, high risk.
Right.
Did
Well,
you choose father's age
with
also?
the cell-free fetal DNAs, it's with those individuals in a high-risk population.
Right.
So in those 4 categories, and so now you're dealing with just cell-free information versus direct fetal information.
Well, now there is evidence to show father's age is also very important.
Right.
Have you considered that also?
It's a little harder to get sampling from dads,
Yes.
whether they're in the picture or what have you, and so, yeah, if we have somebody, if we're doing expanded carrier screening, we certainly need to. A lot of times we'll need to do that. Get the father's input for that.
Okay. Another question over here? Yeah. You wait for the microphone. Go ahead, Rick, please.
So at some point you mentioned that one problem would be there are no enough DNA from the fetus.
Right.
So I'm just curious how difficult it is to collect DNA from mother's blood to separate the fetus DNA.
Well, it depends upon the techniques. The 2 companies, they use different ways of dealing with it on separation. So what they'll do is they'll have their one calls it a Dante and Forte techniques. These are all proprietary techniques. But there's a direct DNA separation initially, and then they go from there. Whereas Sequenome and Verify, they just use proportions of DNA. Now, if you look at, you would think that all aneuploidy would have an increased amount of cell turnover, thus higher amounts of cell-free fetal DNA. That's not the case. Down syndrome does have a higher fetal fraction, but trisomy 13 and trisomy 18 do not. Even whether they're mosaic or not, it doesn't matter. Even though with Down syndrome, they do have a higher fraction, even with mosaicism. you know, the aneuploidy is looking at all the down the road is going to be a major issue. There are also there are a couple techniques of methylation, of separating, because fetal DNA is much more methylated. So that's an operation and a couple ways of also separating them.
Hey, Piotr?
I have one question. So, is it true that fetal DNA is larger than maternal? Molecules are larger than maternal, and you can size select for the fetal.
They do, but they're all it's all fractionated still. Yeah, just like what you were doing. It's all fractionated down because it's in various stages of being degraded by the gyrases and all.
So what you say that I will find everything in this one peak, the same like maternal will be fetal.
Right.
Or fetal will be a little bit bigger. This is my point.
Yeah, no, it all depends, but they're all proportionate. So they're not only proportionate across the board, but they're also proportionate with each chromosome. So chromosome 1 has much more DNA than chromosome 20.
Allan, I actually have a question too. Sorry, Rick.
Sorry.
Invoke my privilege. Okay. I had the impression that most micro deletion and duplication syndromes tended to be de novo and tended to be dominant, but you gave an example where the mother was normal, and so I wonder if you just have sort of an impression or a breakdown of so what are the spectrum of transmission? Is it predominantly de novo dominant? So speaking specifically
Right.
of microdeletions and duplication syndromes, because this is sort of a very different animal than,
Right.
you know, germline inherited.
Right.
Yeah.
So of the de novos, there was about, actually I'll turn it around. Of the inherited types, there were about 10%.
Okay.
Yeah, it's like 9.8, something in that range.
Okay.
So we do, you know, triads on the parents.
Okay.
Yeah,
Okay.
or when we can.
Okay.
So it's but again, you know, you have a situation where mom or dad who carry the deletion could be perfectly fine.
Okay.
Or at least reasonably fine and have a child that's highly
So the
or
10% you're
dysfunctional.
saying, 10% were de novo or 10%?
No, those were inherited.
10% were inherited, 90% be de novo,
Right.
then at least neither
Right.
parent had them.
Right.
Okay. All right.
Right.
Good. That's very useful information. Thank
Yeah.
you.